welcome to another Facebook Live. This is in continuum. This is the very nice patient that I did the Facebook Live with yesterday. She's the nice 68-year-old lady. Her first set of implants was 1984, silicone above the muscle. And then the right one ruptured. She got them replaced in 1998. That's when they found out that right one was ruptured. She had what was free floating silicone on the right side, questionable on the left, and so she got her second set in 1998. So as you will see over here, you have what is the 1984 implant silicone. The right was known to be ruptured at the 1998 surgery. The right had capsular contracture. And then a year later, she ended up getting left capsular contracture in 1999 on the left side. The right one was relatively soft. So as you will see over here, the Baker's classification, you have 4 types of contracture. Grade 1, which is normal. Grade 2, grade 3, grade 4. She had grade 4 on the left, where she had chest, breast deformed and painful. An implant was palpable and visible. So this is the grade 4 that she had on the left side. And if you look at the left side, look at it, literally looks like a heart. How cone shaped it is right here, and how irregular this is. This is contracted in, and she was getting this pain for almost 26 years on the left side. And so now going on to the right side, I'm going to have a fresh pair of gloves, sterile on the right side. You will see I cut out the excess skin for contouring purposes. And I had marked pre-op, and as you will see, this is what is a complete end block. The entire implant capsule is removed. Remember, the volume is very precious. This was the fascia of the pectoralis major was incorporated along with the capsule, so this end block was done. You can see this tissue, small amount that I removed because it is abnormal, irregular, it is nodular, scar type, and this was towards the bottom part. And so this tissue, as you can see, I'm going to go ahead and cut this open. This is the end block. You will see this is the inflamed tissue. As I try to even cut it, it is hard and irregular. So we do not know if this is ruptured or not. And this is from 1998. So 27-year-old set of implants. Celtex. You can see there's fluid around them. Appears to be intact, and it is intact as I touch and look at it. And so as I pull this out, you will see some fluid around. So as I go like this, you will see it is behaving as if it's ruptured. A lot of this slime, if you will, all contained. None of this spilled into the chest. And again, if I were to just show you like this, you will say, oh, it looks like a ruptured implant. No, but this is that gel bleed consistency, extremely slippery, slimy, and this is what's coming out of this. Now, if I go hold this, look at how thin. Look how thin. If you look over here, you can actually see saran wrap thin. If I put it right on top of the ruler, you will see how thin this is. No matter how thin the capsular tissue is, it has to be removed such that if there is any fluid, whatnot else on the inside, it is all definitively, completely, sincerely removed. So if I put my glove here, you will see how thin this tissue is. So by incorporating the fascia of the pectoralis major, I use the word pretty much guarantee that I'm not going to cut into the capsule, and that is the complete definitive way. I'm going to say it one more time. So by incorporating the fascia of the pectoralis major, I pretty much guarantee complete removal of the capsule. And as you can see right here, overall everything looks good. Now I'm going to remove my top glove, and we're going to go to the left side with the left, and you know, this is for my Michigan State on the left side. That was University of Michigan on the right. So this is the left side. I removed some of the excess skin. So the distance from the nipple to the crease on the left is 5.3 centimeters on the patient. And this is where I can ensure that I'm going to cut a little bit more on this side versus this, so as to allow for aesthetic complete closure. As you will see, there's a lot of inflammation here and very super tight. There's some calcification here as I palpate. You can actually make out what is this capsular tissue that's super tight. You can see it's poking it. She had pain on the left side, gun and block. Look at the way this is like literally looking like a heart. As I go in, the tricky part is leave behind all good tissue and remove only what is bad. And as I go in, I'm going to show you this tissue does not look healthy. You can see it has a nodular consistency to it. Maybe that's spilled silicone. And I don't like how this looks. You can see how dusky this looks, right? It has that brown tinge to it. And that's why I removed it completely. So as I go in, I don't want to damage my implant here. So I'm going to go in from here. Hopefully I find a good access point. This tissue that I've removed is unhealthy, and that's why I removed it as well. Let me find a way to enter. Let me go in from this side. Very inflamed tissue. Contracted. There's a lot of what appears to be. Remember, I do not know if it's intact or ruptured, but just the fact that they are that old, from 1998, statistically puts them at a higher rate of rupture. Remember, they are not lifetime devices. I'm going to go in from here. Super tight. As you can imagine how this was sitting on the patient's chest. And we are very grateful to her for sharing her journey as she does her level best to educate, and we learn from these experiences. No one should have to live with a grade 4 contracture or even a grade 3 contracture. No one should live with pain. Everyone should understand they're not lifetime devices. It's very hard and very slippery. So what I'm going to do here is I'm going to go in from here. You can imagine, look at this tissue, it's not healthy, and that's why it was removed. Remember, it's textured, so it adheres, sticks to, and it's literally super glued to the implant. I'm going from here. Okay, so here's a nice good entrance point. You can see this is already ruptured. Remember, none of it spilled out into the chest. You can imagine how much spillage would have occurred had this opened up in the chest. And this is why, if you ask me, you always assume they're ruptured as you go in. Yesterday, both of my implants were ruptured on the same patient where the MRI stated it was intact. So on this case, as you will see, as I go in, look at this poor implant, how it was literally bunched up, and literally how the shell of the eggshell, if you will, all calcified. And very sharp, by the way. So as I turn this around, you will see, look at the entire capsular tissue, the inside of which, and you can only imagine how much inflammation there is. So I've had many patients ask me, even question me, why do you remove this tissue? All of this calcification, the tissue around, who knows, there might be a focal rupture here. You don't want this to be left behind. Look at this tissue. It's gray, dusty appearance. Look at this tissue right here. It does not look healthy at all. It has the brown, dark brown tinge to it. So that's why I removed it. Look at this one. This is very interesting. Look at this tissue right here. So this is grossly consistent with what is a silicon granuloma right here. So as I cut this open, you will see this is abnormal. And that's why I remove not only the capsule, plus the implant, plus this bad tissue, so that all of this nodular tissue, abnormal tissue, by palpation visualization is removed, with only good healthy tissue remaining behind in the chest. So as you can see right here, this is your implant. 375 cc's, and as you can see, look at this ruptured left implant. So you never know what you're going to find when you go inside. This is your textured 375 implant, and the right one is intact. The end block gold standard. No fluid was noted, so nothing needs to be sent to cytology. One has to always assume that the implants are both ruptured till proven otherwise. So as in this case, the implants will be returned to the patient, capsules to be sent to pathology, rule out that rare BIAL, CD for the analysis, rule out lymphoma, rule out malignancy. Look, the capsule on the left was hard and calcified and thick. The one on the right was super thin. Cultures for aerobic, anaerobic, and fungal. Number 4, twilight loop sedation. Number 5, no need for a lift on this patient because you can see she has severe inflammation on the left and also on the right. Number 6, the high definition pictures and videos of the chest wall showing complete removal of implant capsule. Implants will be returned to the patient, and this nice lady got the same surgery that all patients get in the same manner. 20 years from now, I cannot imagine this surgery being done any differently, because everything is contained. Nothing bad was left behind. I assumed that both of them were going to be ruptured, which is the smarter, better, wiser way to proceed with the surgery, and that she is not going to get drains, and we'll see aesthetically how she's going to look minus this inflammation. So there you have it. This is Dr. Khan, Executive Plastic Surgery.